all of this was being done not in the hope of export and making money, but purely in order to meet the needs of the national immunization program. On the other hand, the people with whom they were collaborating, and that was notably Jonas Salk and Gérard Mérieux. The Fondation Mérieux is just round the lake from here, actually. They were interested, Mérieux and Salk were interested in getting IPV introduced in other parts of the world. But that would mean doing clinical trials in tropical countries where the need was greatest. And it is said that this institution, the WHO, resisted their doing those trials because it would interrupt the rollout of OPV, which was then starting up. Anyway, the important point for this purpose of this talk is that there were no patents involved. Salk's famous phrase, "How can you patent the sun?" He thought it would have been immoral to patent. So polio vaccine could be made all over the place. Anybody could get the seed strains. And for example, in Mexico, the first IPV was produced by 1956. Actually, in 1960, they went on and established an Institute of Virology and were soon making large quantities of OPV and soon exporting them. In fact, quite rapidly, Mexico became not only self-sufficient in EPI vaccines, but was also exporting them to much of Latin America. Knowledge in these days was freely exchanged and freely available. This gentleman, Hans Cohen, the young one sitting there, that I quoted before, became the Director General of the RIV, the Dutch State Institute, in 1979. And here in an interview, he's telling about how they collaborated in those days. They simply exchanged know-how, and it was a free and easy collaboration between the State Institute and private institutions such as the Institut Mérieux, which is always a company. The situation in the US was very different. The US relied almost totally on private producers. I'm taking my 30 minutes, I'm afraid, 25, although we started late. The United States relied almost exclusively on commercial producers, almost exclusively because two states, Michigan and Massachusetts, had vaccine production for their own residents. They don't anymore. However, many of the pharmaceutical companies that, remember, I said had flocked into vaccine production in the 1950s were slowly drifting out again. And you can see the shape of that graph, but the numbers not. But the point is that there was a declining number of vaccine producers in the US in the 1970s. And for some crucial vaccines, including polio, there was only one producer. And at the political level, they were getting worried. What if those producers decided not to make vaccines anymore? After all, pharmaceuticals could be much more profitable. And it happened. For example, Eli Lilly, which is a very large pharmaceutical company, in the mid-1970s stopped making vaccines. And they said, well, it's because they're more difficult to develop and to test and to license. They cost much more, they're less profitable, and crucially, there's a big risk of damage claims if something goes wrong, because after all, vaccines are given to millions of healthy babies. And for all of these reasons, Lilly withdrew, they stopped. And at the political level, there was a real anxiety about the security of the vaccine supply. So what happened? In 1986, the US Congress passed legislation establishing a national childhood vaccine injury compensation program. Companies would be insured. If anything went wrong, the state would pay. And so they began to drift back again. However, even more important was the emergence in these years of new ways of making vaccines through biotechnology. Instead of bashing a microbe on the head, you could do much more sophisticated things in the laboratory. And moreover, and again in the US, in 1980, they'd had a piece of legislation called the Bayh-Dole Act, which had enabled and indeed encouraged university researchers and government researchers who made a big discovery to patent it and commercialize it. So what you soon saw was all the expertise in these new ways of making vaccines was moving into small high-tech startup companies. And these, for many of them, their patents was their only asset. So they guarded it jealously, as you can imagine. And so we see the kind of know-how, as Hans Cohen had called it in that interview. What had previously been know-how was now becoming intellectual property. It's been privatized. Now, a consequence of this and of the free market thinking that was sweeping the world in the 1980s was that, for the first time in the Netherlands, some politicians began to question whether it was wise for the state to be making vaccines. They'd always been seen as an essential tool of public health, but there were voices now, I mean, there were many who were seeing them far more importantly by the 1980s as a potentially marketable, high-tech, high-value-added export commodity. And in the Netherlands, there was a tension between the Ministry of Health and the Ministry of Industry about, what should be done about state participation. And the Ministry of Health tried to protect the State Institute by changing its status. And they looked for all kinds of strategic partnerships with Nordic countries that also had state producers. And in 1990, they formed a network, but it didn't last long. It collapsed. The same thing happened, by the way, in Latin America, where a network called Cireva was set up by PAHO, but that soon collapsed as well. Although the decision to end public sector vaccine production in the Netherlands was only taken about 5 years ago, its roots go back much further, to the 1980s, when its viability and legitimacy were starting to be eroded. Pharmaceutical companies, increasingly multinational, jealously guarded their intellectual property rights. The relationship that the RIV had with Mérieux in the 1970s, that I talked about before, had become unthinkable by the 1990s. Indeed, by this time, Mérieux as a company no longer existed. It had acquired the Canadian Connaught laboratories, become a wholly owned subsidiary of Rhône-Poulenc, and it would soon be merged with Hoechst to make Aventis. Public-private collaboration, which in the 1970s had been so free and easy, was becoming a problem to which we'd have to look to invent solutions. So we created the problem, and then we had to try to invent so-called public-private partnerships to deal with it. The Institute in the Netherlands, the Institute's room for maneuver was being drastically reduced. Commercial manufacturers wouldn't collaborate with it in the same way. But this isn't the whole story, because it wasn't only on the production side that things were changing, on the demand side as well. In 1986, the Dutch government decided that children should be vaccinated against mumps. Why? Nobody in the Netherlands or any part of Western Europe thought mumps was very important. Nobody died of it. The point is, a new kind of criterion was becoming important in determining, in shaping vaccine policies. It was no longer just saving lives, but it was also saving money. And children who got mumps went to the doctor, and that cost money. A few went to hospital where they were treated with antibiotics, and that cost money. There was a different rationale was emerging, combined with the fact that increasingly in the Netherlands, there was a sense that they would have to do the same as the neighboring countries. And the neighboring countries were all turning to MMR. policymakers worldwide were starting to accept the idea, it was becoming a dogma of international health discourse, the public sector producers were all antiquated, under-resourced, ill-equipped, badly managed, suffering from political interference, and they were increasingly being closed down. A number of them in Australia and Sweden and Mexico, and many more were, and of course in Eastern Europe, but for other reasons, were being closed down. In the Netherlands, the government continued to resist. I don't know if that's readable. That's a list of all the Indian vaccine institutes that have been closed down. I can give you, anybody interested, a better version, a readable version. I couldn't make it any better. It comes from Madhavi, my collaborator in Delhi. The government resisted these, and it again changed the status of the institute to try to protect it. Even in 2002, it was saying, we need a state capacity to make vaccines. They're an essential tool of public health. But in 2009, they changed their minds. A new government, a new Minister of Health, and look at the reasons, doing the same as everybody else. So, what's been lost? I don't think anybody expects that the pharmaceutical industry will withdraw from vaccine production like it did in the 1960s and 70s. The point is that the classical vaccines, which are still the cornerstone of vaccination programs in most of the world, have little commercial appeal. By incorporating an expensive new antigen and selling only the combination, they can make it all profitable. And I think many countries are going to find themselves obliged to administer vaccines for which they feel no need, supported in the short term by donor funds, but no longer having the possibility of producing or even purchasing the vaccines that best reflect their needs and resources. Thank you.
So our second presentation today will be jointly made by Dr. Jan Hendriks and Dr. Martin Friede. Jan Hendriks is currently the project manager of the WHO Global Action Plan for Influenza Vaccine on secondment to the World Health Organization by the Netherlands Ministry of Health government since 2013. Biologist and immunologist by education, he previously worked from 1982 till 1985 for WHO on infectious diseases in Jamaica and Brazil before returning to the Netherlands. In 1990, he became training coordinator at the National Institute of Public Health and Environment in Bilthoven for several vaccine technology transfer projects to low and middle-income countries, notably in Asia. This work included organizing in 1990 the WHO pre-establishment meeting of the Developing Country Vaccine Manufacturers Network. Martin Friede led the technology transfer initiative within the unit of Public Health Innovation and Intellectual Property in the Department of Essential Medicines and Other Health Products. This team has provided a range of technologies, primarily in the area of vaccines and biologicals, to manufacturers in developing countries. Prior to joining WHO in 2003, he held several senior R&D management positions in the biotech and vaccine industries in Europe and USA. He holds a PhD from the University of Cape Town. Jan, please.
Thank you very much. I would like in this, hopefully not more than 15 minutes, try to bring two messages to you. First, despite this nice introduction in history on public sector vaccine production and the decline, public sector vaccine production I will argue, is not dead if you look at the globe. And the second key message is that the history of the past decades of the Netherlands Institute in Bilthoven has had a not planned but really measurable and widely acknowledged impact for global health. So currently there are still quite some countries with a strong public sector production capacity. China, Indonesia, Brazil, Vietnam and Cuba. With the exception of Cuba, all these countries have a large population, and most of these countries and these institutions have been charged by the government to provide vaccines mainly for their own population because of the size. These, let's say, manufacturing entities globally, and also a number of private manufacturers globally, are since a couple of years united in a global network called the Developing Country Vaccine Manufacturers Network, which currently consists of about 40 manufacturers from 15 countries. And if you look at this slide, you see that the majority of these manufacturers are located in the southern part of the globe, and also the numbers indicate the birth cohort. So the interesting part of this global picture is that you see these manufacturers in developing countries, or more popularly in the WHO areas, low and middle income countries. They're all located in places where the population, which is the customers, reside. Of these about 40 manufacturers, 16 are public, and these are a few examples of them. And a concrete example is Brazil. Brazil has a large population, and in 2011 a paper showed that about 50% of all the vaccines used in the Brazil immunization program are in fact provided by two main manufacturers in São Paulo and in Rio de Janeiro by respectively Institute Butantan and Biomanguinhos. So the entire vaccination program shown here with all these vaccines are in the order of annually 200 million doses. More than half are made in Brazil, of which 46% of those 56% are made in Butantan. I must add to this that these are not completely 100% Brazilian products, because in some cases there have been established popular now public-private partnerships with global manufacturers that do not belong to the DCVMN, but that do belong to multinational company associations called the IFPMA, such as Sanofi or Merck or GSK. These have established long-term partnerships with local public manufacturers in order to provide technology for eventual local production. The network, and I would like to make the link with the previous presentation, is also a little bit related to what happened in the Netherlands, because in early 2000s this network, DCVMN, emerged, and this was mainly coinciding with the decision of the Gates family, to decide to use most of their fortune and invest it in vaccines. So the Gates Foundation was key in developing the Global Alliance for Vaccines and Immunization, the GAVI. So that the manufacturers in the southern part of the world developed a network in order to anticipate potential support from the Gates Foundation and the GAVI to get more vaccines to their population. So the little role that we played in the Netherlands was that after a first meeting of public sector vaccinology institutions in Geneva in WHO, a subsequent meeting was held in Bilthoven, which then existed of about 20 manufacturers here in this picture on the left in 2001. The objectives of this network were mainly to get recognition of their role. In fact, they provide the majority of vaccines in the world in terms of doses, not in terms of money, but in terms of doses. A lot of the vaccines globally are coming from members from this network. So get recognition, and they also wanted to invest in international support for pentavalent vaccine development and production. Pentavalent is a combination vaccine, DTP, hepatitis B, HIP, and what is the fifth one? The fifth, DPT, HIP. What was mentioned by the previous presentation was that the Dutch have developed a technology to provide vaccines for their own population. And I think in that period, the key characteristic is that it was a semi-industrial innovative technology to increase quantity of vaccines, mainly DTP in bioreactors, and also in the use of viral vaccines such as rabies and polio by using microcarriers. Microcarriers are little beads artificially made that you can grow you can put into a bioreactor, which on these adherent cells grow, and in the cells you can grow the virus. And by putting this large surface increase per volume, you get an enormous increase in quantity. This is the key characteristic that made it possible to enhance the inactivated polio vaccine, which was used for application of IPV programs. And it also allowed other vaccines of viral nature that grown in cells to be produced in large quantities. In addition, purification techniques were developed that were enabling better purified products. These technologies, actually taken together, are seen as unique because it's not only one trick you do in a lab and then transfer, but the entire infrastructure which was developed basically for the Netherlands included a facility, technology to make at a semi-industrial level vaccines, and in fact the way that it was shared in a kind of open door policy, as was mentioned by Cohen in his discussion with Mérieux, it was just exchange and freely open door. This production technology sharing was quite unique, and I'm not aware of any other European public institution that has done it on a large scale. There is, of course, a lot of international collaboration and transfer, such as what the NIBSC in the UK has been doing and is still doing, which is sharing information and making available biological standards. But production technology sharing is unique. And as said, there were no intellectual property restrictions. It was mainly know-how transfer and training, capacity building, and it was basically based on long-term relationship, building on individuals and trust. Now, already from in the 80s, one of the key inventors of that technology that was never patented, the microcarrier technology, Toon van Wezel, he died at the moment when a report was just completed under the UNIDO affiliation, which was basically a model program for production of vaccines in developing countries. What was written in that report is that basically the EPI program at that time was simple: DPT, polio, measles. The Dutch had solved that for their own program. So all the knowledge needed to make that, including the logistics and the costs, were all put together in a book for other countries to use if they would like it. And including a layout, how to set up your facility, the routings, what product to produce where, how to do the cleaning, everything was made international. And it was even a kind of assessment if you have for different products a certain number of doses. The upper part of this Excel sheet, by that time there was no Excel, but it looks like an Excel sheet, shows per individual vaccine what is the cost of the production, the control, the cleaning and the filling and the pharmaceutical formulation, the cost per dose. This is expressed in guilders, and for each column you see what one dose would cost in the setting as described in the book. If you look at the upper part, this is for a population of 10 million. If you look at the under part, it's for a population of 100 million. Now, from these figures, it is clear that the more you produce, the cheaper the cost per dose becomes. Hence, the logic is economy of scale. So the technology developed was actually made for larger countries than it was for the Netherlands, because it was only a small amount of need. Dutch population is 15 million. At that time it was less. So we never needed more than for 10 million. But then the cost per dose is much higher than the cost per dose if you would have 100 million. So this principle you will see in the continuation of my story. There was also always an open attitude to transfer by training. It was quite natural that people came to Bilthoven for training. Everything was shown, protocols were shared, and we did also courses together with WHO in international settings. Actually, from 1972 until 2012, there was about 40 courses were held in the Netherlands under WHO support for different topics, all related to vaccines and infrastructure. And in fact, over 400 people from manufacturers and from national regulatory authorities were extensively trained for longer periods. And the key characteristic is hands-on, working on the bench, not just PowerPoint, diarrhea, lectures, but really work in a laboratory setting. This was also quite unique. And I like to show this slide because it shows a key person in present day global vaccine supply discussions. Dr. Suresh Yadhav here in 1984 came to the first international quality control course on human vaccines in Bilthoven, and he spent about 4 or 6 weeks to learn here the titration of the live poliovirus vaccine. He is from the Serum Institute of India. Now, for the rest of my talk, I'd like to show you 2 examples of all this work of what I would argue are really cases that you can show impact on global health. The first is a project that was held in the mid-90s to transfer technology on different vaccines to China, to different public institutions, where at that time transferred technology and know-how on Sabin OPV vaccines were transferred to Kunming at that time in the 90s, but they are now, I think they are the basis of the new vaccine from China that was just licensed in January 2015, which is called a Sabin IPV. Because the 2 pictures here, the most above is the oral polio developed by Sabin, and the one below is the vaccine IPV developed by Salk. Salk is inactivated, is killed, is harmless. Sabin is live, is cheaper, and it is used globally worldwide. But now eradication is near for polio. The IPV becomes more important because the OPV as used nowadays rarely can cause mutations in some cases, and you would have polio due to the vaccine, and you don't want to have that. So that's why IPV is becoming more of use now in the final steps of the eradication. But Salk IPV is difficult to manufacture in an area where there is more risk for calamities. So the consensus of WHO is that IPV should only be manufactured in highly secure facilities, and there are only a few in the world that can do that. But if you would make an IPV vaccine based on the attenuated Sabin strain, that would be much less of a risk. And in fact, Japan has achieved that, and also apparently China. The second example is the conjugate technology that was quite innovative a couple of years ago for a bacterial vaccine that causes meningitis and pneumonia. It's Haemophilus influenza type B. This has resulted, I would argue, in the current situation that the global price for the pentavalent vaccines for GAVI markets has decreased significantly. So the first example, it was a project in the 90s funded by the World Bank. It aimed to transfer DTP, measles and polio technology to 2 different state institutions according to European standards. Upscale, good quality, 3 different facilities were created, and the bar chart here shows all the different aspects, including the process development to be transferred, the training, design and engineering, procurement, construction, etc. Nowadays, halfway of the project, the Chinese decided we can do it ourselves, and it was prematurely stopped. But in 2009, I was able no, in 2011, to visit one of the facilities here in Shanghai on the right, and you see that the building is still being used for vaccine production, and the people that were trained are still working on vaccines, just they decided to do another vaccine, which at that time was the influenza vaccine for the pandemic. And here I show a table to see just the order of magnitude of training. About 80 trainees came for extended periods of time to the Netherlands. They were trained in different areas and for extended periods. So the total amount of training was about 505 training months in the Netherlands. So that's a capacity building project. And the institute in Kunming, where the polio technology was set up with microcarriers and viral cells for OPV production, actually was used by the Chinese to do something different afterwards. In 1997, the project stopped. The Chinese decided we are going to use the OPV technology and we are going to make an inactivation step ourselves, and we will do it ourselves. And then in January 2015 it was announced by the WHO office in Beijing that we can now make a Sabin IPV vaccine in China, and we will use it in our program as of this year in order to complete the eradication strategy for that country. So this was an indirect, intangible result, I would argue, for the part of the project on the World Bank that showed how to make OPV in China. They can use it now to make IPV. I must maybe say that these examples also assume a lot of performance and achievement at the recipient side. It's not that it's one-way traffic. Most of the technology, and especially this example, it's the second example, the conjugation technology, which creates memory T cell, that the immune system will remember an infection better if the product that is offered conjugated to a carrier protein. That's a kind of chemical technology that was became very successful in 2000s. For the Haemophilus influenza type B conjugate technology, it was developed in the Netherlands, but not uniquely. It was already licensed and used, and in fact, for the Dutch program, that vaccine was already purchased on an annual basis. Nevertheless, the technology was available, so it was redeveloped for tech transfer. Not on a large scale, but just for a pilot process. And eventually this has been transferred under collaborative agreements to Indonesia, Biopharma, and India, two private companies, Biological E and the Serum Institute of India. And the upscale, the licensing, the clinical trials, all these responsibilities and the costs associated with that part of the vaccine production process were all borne by the recipients. And now all of these three manufacturers are on the market, on the global market, with pentavalent, which contains the HIP. And what we say is, well, the market has been created by GAVI because they created a global demand. The Dutch Institute helped to at least three manufacturers to get access to the technology. And here you see a recent slide which shows that by the time that these manufacturers came on the global market, the prices were going down to an order that is considered more affordable. Now, as mentioned already, in 2009, the government of the Netherlands decides to stop production in the public domain. What the next step was to offer it for sale. So in 2011, the Serum Institute of India, the largest vaccine manufacturer in the world, acquired the facility, the infrastructure, and the know-how, and also the personnel needed in the Netherlands to produce and quality control the vaccines. So this is now called a wholly owned subsidiary of Serum Institute India, which is called Bilthoven Biologics. So that's a purely private entity. The reasons why the Indians did it is manifold, but one is that they saw a strategic opportunity to establish their company in Europe, and the second reason is they got hold of the real know-how and technology of making IPV at a large scale, and now not as the Sabin IPV. Of the former Netherlands Vaccine Institute at this moment continues to be in an institute called the Institute for Translational Vaccinology, or INTRAVAC, and the government's intention is to place it also outside the public domain, but still preserving public interests. This process is still ongoing. One of the key activities is to work together with WHO on this Sabin IPV project for production and technology transfer of Sabin IPV. I mentioned China, but they did it on their own mainly. But there are also now collaborations ongoing in India, and there's a talk of other projects to make more availability of this IPV variant. Summary and discussion. Globally, my point is there are multiple countries with public sector productions, and they will still remain. They will always have to follow or to find partnerships or collaborations or associations with industry, but they're still there. The technology transfer and capacity building by the Dutch Institute and other public institutions is evolving from producer to producer collaboration to non-exclusive partnerships between innovative enabling platforms and emerging manufacturers. There is a tangible and intangible impact on global health. And I could argue as a kind of philosophical remark, the takeover of the Dutch public sector vaccine production capacity by a private Indian company, is this the ultimate success of technology transfer? Thank you.
Thanks, Jan. So I will be very brief. We've heard about the decline of these. So we're just going to look at some of the reasons why and put this into perspective for WHO right now. And this begins up with a very simple graph. This is the cost of manufacturing of influenza vaccines across a range of manufacturers. And the yellow bars are the size of the facility. So on the left, you see the big facilities that are producing a lot, and on the right, you see the small facilities that are not producing much. And you see the blue line or the green line showing the price that it costs them to produce it, cost of goods. What does this come out of the factory at? And you can see that in the big factories, it's coming out at a price, in this case, about $1 a dose, and in the small factories, it's coming out at a price of about $2 a dose. Now, this becomes very simple. If you have a big market and you can build a big factory, you will produce a large volume of goods, and you will have this at a low cost of goods. So this means that if you're if you're a producer, a national producer in a big country such as Brazil or China or Indonesia, and you're providing for your population, you can justify building a big factory, your cost of goods will be low. Or you can be a multinational and you're exporting to a large around the world, and such as GSK, Sanofi Pasteur, and you're producing in a large scale, cost of goods is low. Or you can be a private producer with large exports, such as Serum Institute of India, which Jan has already mentioned. They don't provide all that much within India. It is mainly provided outside. So they are big, and therefore the cost of goods is low. Now this means the world is being saturated, to a certain extent, with vaccines coming out of the big factories, which are coming out at a very low cost of goods. So therefore, if you are a national producer in a small country, and you're producing for your country, you're basically facing a big problem. That you've got limited local production, so your cost of goods is high. So this means that either the government is going to subsidize you and buy from you, the local producer, at a higher price than they could buy from on the international market, or you, the local producer, are going to have to increase your market. Now, how can you increase your market? Well, you've got to export. But if you export, your quality has to be good. You have to have a regulatory agency that people trust in, and you have to have a marketing department. And for many of the groups that we worked with, this idea of a marketing department is evil. You know, retrobade satana. We don't get into this. This is commercial. So as the two talks have presented, we've had a lot of these companies growing up through this good public health thing. We provide to the local community. We are not going to get into the commercial aspect. But then you reach a situation where what they're providing is more expensive than what could be procured on the international market. And while the Minister of Health is meaning well, that's great, but the Minister of Health sits at the end of the table. The Minister of Finance sits next to the President. And sooner or later, the Minister of Finance says, why are we paying $2 for our locally made vaccine when we could pay $1 for the imported vaccine? So this is where we need to think beyond just economics and look at national health security. So to have a local manufacturer, a national manufacturer, this gives you a national health security guarantee. In the event of a pandemic, the countries that produce vaccines will be the first to get the vaccine. We know this. Even in the 1970s, there was an influenza pandemic scare. Canada, which was producing the vaccine, said to the US, we are first going to vaccinate our Canadians, and then we will allow you Americans to have some vaccine. The Americans did not like that. Now, we're even seeing now shortage of some of the older vaccines. Some vaccines are not being produced. Some of the old vaccines which countries want are no longer being produced. There are shortages. The other thing is a guarantee of cost. Those vaccines might be cheap now, but are they going to be cheap tomorrow? And we've seen that vaccine prices do occasionally go up. So just a quick mention of what we're doing at WHO. There you can see a map of the world with lots of square boxes. This is where we've been trying to get national production of influenza vaccines as part of a national security situation. Some of these are private, some of them are public. But what we have seen with many of them is that if they are small, the whole issue of sustainability becomes a huge problem. How do you get sustainable production if your cost of production is greater than the cost of international procurement? Recognizing that in the event of a pandemic, there will not be international procurement. It will be me first, and then if there's anything left, I'll give it to you. So this is where we've got to think also beyond national health security, and that these national manufacturers can address local or regional needs, for example, making a schistosomiasis vaccine. GSK, Sanofi aren't interested. Brazil is. Enterovirus 71, this is a Chinese disease. Only the Chinese manufacturers are really interested in this. We need to have products tailored to societal needs. So, for example, route of delivery. Are we in a place where we don't have access to doctors that can give intramuscular injections? Would intranasal delivery or oral delivery be better? What about the composition or suitability? Each region has its own specific needs, and only national producers can really take this into account. And then beyond that, we must think, what does this national production bring? It brings industrial development. There's no point training university people in biotechnology if there's no jobs for them. And building biotechnology industry also brings revenue in. And quite often, biotechnology industry has been built out of vaccines. We begin with vaccines. These are relatively easy to make. And out of these come things like monoclonal antibodies, which can actually make you a profit if you're lucky. And, of course, foreign exchange reserves. Countries like to keep their foreign exchange. So if they make it locally, they don't have to buy it. And if they're lucky, they can export it and actually generate foreign reserves. So my conclusions, to be very short, are that national vaccine production, be it public or private, it does not matter. This serves national health security. However, on purely economic terms, small manufacturing plants face challenges to sustainability, and this has resulted in many of the facilities that we've seen collapsing. And we've been working with some facilities. Many of my team are here with me, and we have sometimes gone through facilities where our eyebrows have raised, and they said, do you actually want to make a vaccine in this facility? I wouldn't even want to cook in this facility. And this also comes down to the last point, which I'll just touch on, is that a lot of these, especially the public facilities, they were providing vaccines at cost of goods to the manufacturers, and there was no reinvestment in the facility, there was no reinvestment in skills, there was no reinvestment in R&D. And essentially, as the technology has evolved, those manufacturers that had not reinvested in R&D, that had not reinvested in maintenance of their facilities, they very rapidly fell behind. They were not able to make the new generation vaccines that the government was calling for, or their quality was not up to scratch, and they fell by the wayside. So as we, and I say we globally, all of us in this community, are pushing vaccine prices lower and lower, we must recognize that unless we leave a margin for reinvestment in R&D, this is a self-defeating process. And these manufacturers providing vaccines at cost will sooner or later collapse. And so the line which we give to manufacturers is work with your government and highlight the long-term benefits. It's not just saying, I'm giving you a vaccine which is costing 50% more than you could buy it from next door, but it's, I'm giving you a vaccine, I'm giving you national security, I'm giving you jobs for your population, I'm giving you a reason to train your university staff, and things like that. So with that, thank you.
Thank you, Martin. So now is the feel free, please, to raise any question. Let's give the floor to Sanjoy to chair this session.
Well, as Jing said, we'd be very grateful when you make comments or ask questions that you speak into a mic and identify yourself. And I can already see a hand up, but you're rather far from a mic, so if you could move up and ask your question, please, and identify yourself, please.
My name is Rick Viergever from the Global Observatory on Health R&D, or WHO. I was wondering if the presenters might be able to comment on the differences in research development being conducted at public sector versus private sector vaccine producers, because I've heard a lot about production at the public institutes, but a little bit less about R&D being conducted. And I'd be interested both in the volume of R&D being conducted, whether that's less sometimes or maybe more, but I would doubt it, at public sector institutes, and what if there's a difference in the diseases that are being researched by these institutes as compared to the private sector.
I can take that on quite easily. We've done a fair bit of research on this. So first of all, the bulk of research is not done at the manufacturers. The bulk of research is done at institutes such as the NIH, INSERM, the various universities throughout the world. This is where the research is done. And then this is transferred, especially in the US, because of the Bayh-Dole Act, this is then transferred to what we call translational research centers, otherwise known as biotech companies. And it then goes from biotech companies typically into the multinationals. There is less and less research in the pure sense being done at the manufacturers. In the public sector centers, I can only talk to groups such as the Danish and the Dutch, where there was little being done. Maybe others can comment on this. And in the developing countries, there is almost zero research being done at the manufacturing, be they private or public, other than possibly improved downstream process development, which is just to optimize vaccines.
Just as an addition, at least one of the earlier mentioned state institutions, Butantan, and some of the management has always stressed the need for research and development. And there's a lot of science in the work of the institute. What we only sometimes do not see at WHO level is to see all the science that is done within a public vaccine institution is translated into a product that gets to the market. So there's a lot of partnerships involved nowadays, and I think there's also a lot of things going on in China, where there's enormous amount of public and private entities that are working on different parts of the value chain, as we call it, from discovery to licensing and follow-up. So I think the world is changing tremendously. But the real point that Martin said, I think, and what you also mentioned in your question, is that this seminar was focused on production, which is necessarily not addressing all the intricacies related to the R&D part of the value chain.
Brief follow-up question. So I'm aware that many of the public sector is engaged in early stage development often, and then at some point it gets transferred to private sector companies for further development and at the end marketing. Because what I'm wondering, if there are at the moment any public sector institutes that are engaged in that second part of the production chain or the research chain, whether it's public sector vaccine production / R&D institutes, because as I understood it, the Dutch and also the Chinese do some R&D, whether anyone's engaged in that second bit. So I know the first bit is done by the public sector. The reason I ask this is because it's important in terms of which diseases end up getting researched and being brought to the market.
Yeah, Stuart says, what about Cuba? But Cuba is a very special case. Cuba has really been very successful in getting vaccines to the market out of a national strategy. And in Cuba, until now, everything what is done is public by their particular nature. So that is an exceptional case where you see a very good integration of all aspects of the value chain. What we learned over the past years in the Netherlands, what is now called Intravac, it tries to be the bridge between, let's say, discovery, academia, and the manufacturing. Because you must understand that it's a different kind of knowledge you need to produce routinely according to SOPs, with meeting specs, meeting regulatory standards, and to develop or a discovery in the lab into a consistent process. There are different climates of knowledge and people. And I think it's not realistic to expect that there will ever be a public institution that will continue to combine all these aspects into one entity. It's too complex.
We have a question online from the Oswaldo Cruz Institute in Rio de Janeiro, Brazil. So Dr. Human Momen says, congratulations on the excellent presentations. What has been the reaction by the Dutch public to a public vaccine institution being taken over by a private Indian company?
I think most people are not even aware. It was not really advertised as we do it now as such. Maybe there are other people from Holland in the audience, maybe you can comment on this, because I'm biased. I think I'm also surprised it was not so much of a political point, but it has passed quite silently up till now.
I think many of us in Western Europe are becoming used to this process of reverse colonization. It's not the first industry that's been taken over by a company from the global south. But it really, as Jan said, this virtually no publicity in the newspapers, in the media. It's not been discussed. It's not raised any passions or concerns.
I mean, if I'm right, the Serological Institute of India is still a public company.
No.
No, it's also gone private.
The Serum Institute of India is completely privatized. It's a family company.
Okay. So thanks for great presentations. Really, really insightful. So I'm an intern in IVB. And my question is, you've talked quite a bit about the increasingly stringent GMP requirements, large capital costs, the need for reinvestment into R&D, and how research and development in public facilities is usually restricted to the initial part of R&D. And my question is, how far do you see the feasibility of having public vaccination manufacturing? How far can it go? Can it go to that point where we do the second part of R&D? Can it go into production? In this day and age versus the past, how has the change in climate affected our ability to even start something on the same lines of what used to exist?
So I'll be a bit controversial maybe and say, why does it have to be public? What's wrong with the private sector? The bulk of our pharmaceuticals, which keep us alive every day, come from the private sector. So I think the real question is actually not public versus private, but national versus multinational. And as we go forward, I think we've made the easy vaccines, and these easy vaccines are being produced in bulk. We're beginning to hit the difficult stuff now: TB, malaria, HIV. And here, huge capital investments required, both from governments to support research, as well as from big agencies to support the translation. So I don't think it matters whether it's public or private. What matters is that it's done.
Jose Hansen, I'm from the EMP department. On the economy of scale, like you said, well, I'm a former regulator from the Netherlands. And one of the reasons to close down at that time also the production in the Netherlands was too small, and it was not cost effective, and from a GMP point of view it didn't comply. And then to Martin, I don't know whether, well, you could ask what was the reason at that time to have a public production of vaccines and not for all the other pharmaceuticals. And one of the characteristics of the pharmaceutical market is it it's an applicant-driven system. And when there is no application for marketing authorization, there's no pharmaceutical or no vaccine, and we face that with the AMR. The whole discussion on AMR is, of course, because it's not profitable enough to be developed. So the question is, at what point there is not such a drive or a profit for a pharmaceutical company to produce or to develop and produce. And we face that with antimicrobials and perhaps also with some of the neglected diseases. Apparently, that's not the case currently with vaccines, but it may happen. So I don't know whether it's that simple as you say, whether it's national or international or private, public. There's a lot more to this. And I think to have, well, the criteria should be R&D, availability, and of course affordability. And who is best to provide those three things? I don't know.
Isabelle Vaxmut from Knowledge Ethics and Research Department. And about what you say, you have some recent initiative, about clustering. It is, for example, the case in South America when you have different countries, decide to produce together. It is some national, in fact, company are together, to increase this type of production. Apparently, I have not the information that exists in Europe, but it is one way, to have this scale, of the production. I know you have this example now. I think it is Brazil leading this type of initiative, with different other South American countries, But that can be one answer as well. I have not the details, but I know that exists now.
Tim, is there another room booking? Or there is. So, unfortunately, we'll have to wind up today because there's some people waiting to come in and use the room. I'd like to thank all of you for joining us, especially all of you who stayed. Usually I thank the funders, but we're in the fortunate position of having Dan, Nick, and Joao, three colleagues from the Wellcome Trust here. So thank you face to face for all your support. 89. Yeah, Dan has been threatening to pull the plug at 99. I'll try and convince him to let us go to 100 and then he can pull the plug. But honestly, it's wonderful to have the speakers present three wonderful papers, the discussions between different WHO departments afterwards. And the next GHS seminar is in September, and it's going to be on climate change and health. And we're hoping to entice a very well-known anthropologist from the United States to speak with a colleague from the WHO. So thank you, and please join us again in September.